So, okay, yes, we do. So in V1 here, you got a downward deflection. That is downward deflection. Look at V6. So V6 here for VTAC is this. So upward, this one is upward. So we have a VTAC. Okay, so that's for concordance. If it's all going to the same direction, if the direction is all in one, like this one here, it's easy. From V1 to V6 and they're all downward, it's easy. Well, we have a VTAC here. Concordance alone shows it. So from V1 to V6 is all downward direction. Okay, so that is concordance. If concordance is not there, then go straight to your, checking here, am I dealing with a bundle branch block or it is VTAC? So you have it here. I wrote it here. Okay, there we go. So if your VTAC is positive or upward here, is it with bundle? Is it SVT with right bundle or it is VTAC? So there's an upward, that is also upward. But look at your V6 and the V6 here. If you have a left bundle appearance in your V1, look, your left bundle is downward. Your VTAC is also downward. Now take a look at your V6 and the V6. That makes the difference. Okay. So not all VTAC will show you a good concordance. Some are not. So proceed to these parameters here and check the difference. Okay. So that's for concordance. AV dissociation. AV dissociation, sometimes the VTAC rhythm, sometimes the ECG with VTAC will show you P waves. I don't have that example here. But the P wave should not be uniform. It could be wandering. Sometimes you might be seeing a P wave somewhere there, okay, somewhere here, or it could be going downward here, but it has nothing to do. It's like a complete heart block here. They're totally have their own world. Okay, so the HL will just does its own thing, will do its own thing, and the ventricle will just do its own thing. So they're not related to each other. So sometimes you see P wave on these QRSs, and that is AV dissociation. I'll try to get I'll try to get a sample with the next, the SVT next time with our next video. Okay, so AV dissociation, so they mind their own business. So that's it. So ventricle is different, HL is different. They're not related. No relation. Okay, and the bundle branch block, as I said, proceed. If you have this, is your VTAC coming from the right ventricle or it's coming from the left ventricle? So there's an example here, the right ventricular outflow tract. The VTAC is coming from the right ventricle right here. So you expect to see a left bundle. Okay, that's a left bundle here. If your VTAC is coming from the apical or for the left ventricle, you expect a right bundle. So V1, right bundle. If your VTAC is coming from the left ventricle, the V1 will show you a right bundle branch block pattern. If your VTAC is coming from the right ventricle, you expect here a V1 with left bundle branch block pattern. Okay, so what are the factors that can induce your ventricular tachycardia? Ischemia. Ischemia from your unstable angina, from your non-STEMI, or it could be an infarct from your STEMI. Okay, hypoxemia, lack of oxygen. Okay, you have also electrolyte imbalance, especially low potassium. Drug toxicity, like in the case of drug, digoxin toxicity or anything there, amiodarone or anything. And we have prolonged QT, CHF. So these things are the enemies of your ventricular cells. The ventricular cells become irritable. So if they see that there's ischemia, they produce PVCs, frequent, salvos, triplets, short runs. Hypoxemia. If your potassium is low, they prolong your QT. Okay, drug toxicities. Okay, or if you have a stretch factor, CHF and everything, what happened? You got fluids there in your lungs, you kind of diurese the patient. Okay, we need good oxygenation. As I said, we need oxygen. So anything that there's ischemia, lack of oxygen, imbalance of electrolytes, drug toxicity, there's already probably ongoing problem with QTC, or maybe some medications prolong it. In heart failure, we don't want this because the ventricular cells, they are very they are easily irritated by these factors, and you see them. So what you're gonna do is start checking. Maybe your patient, is the patient having, ischemia, or is the patient ischemic, having pain? Is the patient wet? Are the blood works potassium low or what? And check your ECG last. What's happening? So try and check these things, because it's communicating. These PVCs are communicating to the nurses. There are meetings, so start checking your patients. Okay, so in here, I got this action potential here. As I said, we talk about these 4 as your automaticity period. You got your depolarization, 1, 2, 3, your repolarization, and back to your automaticity, your 4. Okay, so that's it. And the R on T phenomenon, that is your early after depolarization. That is halfway your T wave. And you got your delayed after depolarization, maybe before your P wave or just before the beginning of your P wave here. Okay, so that is a trigger activity of BTAC. Examples here of strips. I got references, but I tried my best to get whatever I could, just to, to give you some like visuals for my discussion here. So we see that in this strip here, you got 2 ventricular beats. So there. So keep an eye, as I said, start checking your lights, check your patients. Okay, that's one. If they're getting frequent, there's something wrong. Probably your potassium is low. Start checking your blood works. Magnesium, potassium, patient. Okay, and your last ECG. Okay, medication ongoing, amiodarone. Okay, start checking. Okay, because if they fall under T wave, that can create a chain reaction of BTAC. Okay, next one here, the same. There's another one here. We got bigems here, ventricular. So you got a sinus rhythm here, and you got bigems. If they keep having bigems there, is your patient ischemic, having chest pain, wet, hypokalemic, hypomagnesemia, or amiodarone, QTC prolongation, all these things? Start checking. Okay, there we go. Then if that ventricular bigems start creating this is polymorphic VTAC, short run of polymorphic VTAC. The QRSs are not uniform, then you're close to having long runs. Next one, you see that will be a long run VTAC. Start alerting yourself, do something. Okay, so there is a VTAC ECG here, which is monomorphic. So as I said, when you try to read your VTAC, you don't read the chest, you don't read the lymph leads. You go V1 to V6. That is your precordial, or chest leads. This is the one that you see, that you check. So you got here all negative deflection from V1, left bundle pattern, left bundle branch pattern. Okay, so downward, down, 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 here not. But as I said, you went and check your parameters. In here, it's down, but on the V6, it's up. So correct. So this is an example of a right ventricular outflow tract VTAC, because it's coming from the right ventricle, and the V1 is left bundle branch pattern. Okay, and the left ventricle apical one will show the reverse. It will be a right bundle in the V1. Okay, next here is another kind of, so this one here is monomorphic, and it is non-concordant. So this one as well, I try to look closer. Again, the same as the first